Of discussion would be nephrotic syndrome in the pediatric age group. So it is defined as a presence of four things: heavy proteinuria, hypoalbuminemia, anasarca, and hyperlipidemia. I mean, heavy proteinuria, when can we say that it is heavy proteinuria? When the protein excretion in urine is more than 1 gram per meter square per day. And how do we test this? We can test using spot dipstick test, or we can check the protein creatinine ratio. Now, if the protein creatinine ratio is more than 2, then that means the protein that is being excreted is a lot. Okay, then we have hypoalbuminemia. So since a lot of protein is being excreted via the urine, our body will lose its store of protein, specifically albumin in most of the cases. So that's why the serum albumin level would drop to less than 3 gram per deciliter. Then we'll have anasarca. Now since the colloid osmotic pressure or the oncotic pressure decreases, what happens is that the fluid will start to shift from the intravascular compartment into the interstitium. So that is why the body will be there'll be generalized swelling of the body. Then hyperlipidemia. Now, since a lot of proteins are being lost via the urine, the liver will be in a threatened state. It will feel that a lot of our protein stores are going to waste, are being excreted via the urine. So it needs to resynthesize all these proteins. But instead of resynthesizing only albumin, which is being lost specifically in our case of nephrotic syndrome, the liver will resynthesize all the proteins like lipids, apolipoprotein, which includes very low density lipoproteins, then low density lipoproteins, triglycerides, etc. So this synthesis of these would increase, but then the lipid clearance, the clearance of these would remain the same. So therefore what happens is that there'll be a mismatch, so there'll be hyperlipidemia. Now, since there is hyperlipidemia, a lot of lipids would be synthesized by the liver. Now, where will these excess lipids go? They'll also be excreted in the urine. So, what will we get to see? We will get to see something called as lipuria. Along with our proteinuria, we'll also have lipuria in these cases. So that's what is that's what the picture demonstrates here. Now this is a picture of a phase contrast microscopy, which basically shows lipids. So you can see the Maltese cross appearance. So this is how a Maltese cross actually looks like, and this is how you can see the lipids in our urine. So then we've already seen the dipstick assay score. It should be over 3 plus or 4 plus. So what is it? So basically this is a strip, and it's a plastic strip, and it has different colored bands. So when you dip it into a container of collected urine, then you'll have a reference image which is pasted onto a box, and using this reference image it will indicate which substance is present in excess in the collected urine. Then we can see this is an example of anasarca. You can see that the child is having generalized swelling of the entire body. You can see the abdomen is swollen up, the legs, you can see the face, and then the arms, and you can see this is a photo of periorbital puffiness. And why only orbits? The periorbital area, the retroorbital region is the first to be affected. Why is that so? Because the tissue around your eyes, they are very lax, they are very loose, and the connective tissue is very thin. So therefore it is very easy, if the fluid collects there in these regions, it is very evident. But then whereas in regions like your abdomen, in your thighs, lot of fluid needs to be accumulated in order for it to be evident. Then we look into etiology. More than 90% of the cases, they are idiopathic or primary, and around 10% are because of amyloidosis, systemic lupus erythematosus, or vasculitis. If we talk about predominance, it is predominantly more common in boys than in girls. Then we can classify it based on two. First, we can classify it histologically, and then second, we can classify this disease based on its responsiveness to corticosteroid therapy. So histologically is not very important. It can be divided as non-proliferative glomerulopathy or nephrotic syndrome with glomerular lesions. And second, if you go into the more important one, which is corticosteroid classification, it could either be steroid sensitive nephrotic syndrome or steroid resistant nephrotic syndrome. Now, from the name itself, it's quite evident that when a disease is responding to our therapy, then it has a better prognosis, and the one that is resistant has a worse prognosis. So that's the same. Now, in most cases, nephrotic syndrome is a steroid-sensitive nephrotic syndrome. Now, when a patient comes to the pediatric OPD with all the clinical features and all the signs of nephrotic syndrome, let's say hypoalbuminemia, anasarca, complete swelling, periorbital puffiness, and all of this, the first thing that we'll suspect is nephrotic syndrome. So, what is the first treatment that we would give? We'll first give steroid. Now, if the child responds to steroids, then it is better. If a child responds to steroid, it should always be because of something called as minimal change disease, which we'll look into in quite a while. And minimal change disease is a cause of steroid sensitive nephrotic syndrome. Now, It is defined as nephrotic syndrome that achieves complete remission of proteinuria with corticosteroid therapy. What is remission? Remission is nothing but the disappearance of proteinuria or all the other symptoms associated with nephrotic syndrome. Now, why exactly does this entire nephrotic syndrome, what happens? Why does this occur? Now, this is because of an immune dysregulation. So basically, our immune system, they get confused and they go and start to attack the podocytes, which are present as a barrier in your glomerular junction. Now, to simplify it further, this is a picture, this is an illustration of our glomerular filtration barrier. So this is the glomerular space where there is urinary filtrate, and this is the capillary space where there is blood, as we can see here. Now, what is this called? This is our glomerular filtration barrier, which is the first layer, then we have the second, and then you have the third layer. The first layer is called as the glomerular basement membrane. What does this contain of over it? It has your podocytes. Now, these podocytes will have something called as your food processes, podocytes and their food processes. And then what do we have something known as a filtration slit. This space is known as a filtration slit. The bridge which is connecting these podocytes is called as the slit diaphragm. Okay, now this is what comprises our glomerular filtration barrier. This glomerular filtration barrier is damaged by our immune cells in nephrotic syndrome. So what happens is that our T cells, they'll become dysregulated, they'll become confused. These T cells will come and attack our podocytes. Now what happens, these podocytes will lose their negative charge. Usually these podocytes, not usually, they are negatively charged, and proteins which are here, and these proteins will try to cross the barrier, they'll try to enter into the urine. But what happens is that the podocytes are also negatively charged. This like and like will repel each other, and that's why in a normal person proteins are not excreted in the urine. That whereas in this T cell immune dysregulation, what happens is that the T cell will completely destroy your podocytes. So the podocyte will lose its charge, whereas the protein will have its negative charge. When the protein comes to its podocyte and it will try to cross the barrier, the podocytes will allow it to cross because it does not have a negative charge. Now, this is the main pathology as to why we have proteinuria, because the negatively charged podocytes are damaged. Now let's look into the pathology. Now this is caused mostly steroid sensitive cases mostly indicate that it is because of minimal change disease, especially if the child responds to steroid. Now you give a dose of steroid and the child is well and the symptoms have decreased, and it is most probably due to minimal change disease. Now what is minimal change disease? As I've already explained earlier, it is the effacement nothing but damage of negatively charged food process of podocyte, leading to negatively charged proteins are not being repelled. Therefore, there will be excretion of proteins, albumin. Why only albumin? Because albumins are very small in size, and the damage is as such that only a small portion is damaged. So therefore, the albumin will fit into the space. So that's why only albumin and not globulins, etc. Now, it typically affects children 2 to 6 years old. There is selective albuminuria. It is and why is it called minimal change disease? We can wonder why is the name something unique and something to think about. It is called minimal change disease because if we take a microscopic section, everything seems normal. There isn't any significant glomerular lesion. No significant lesion. That is why it is called as minimal change disease, because there's hardly any change if we take a section and if we see the microscopy. Now this is the pathophysiology. It's what I've already explained. It is because of immune dysregulation, which is likely to be because of T cell, and it caused damage to the podocytes, leading to effacement of the food processes. Then the glomerular filtration barrier, which is nothing but our GFB, which I just explained here, it is damaged and it is lost. And selective proteinuria because of its small size. Now this is how a normal capillary, yours and mine, looks like. But then this is how the capillary, or this is how the picture of a person having MCD, minimal change disease, minimal change glomerulopathy looks like. We can see the effacement, we can see how it has fused, and how we cannot see the food processes and the podocytes here if we compare it to this image. Now, in case of steroid sensitive nephrotic syndrome, but then there's a catch. So since we are giving a long-term steroid therapy, there has to be some repercussions, right? So that would be relapse dependence. So first, let's look into relapse. So what is relapse? And when do we say that a child is having relapse? When there are more than 2 relapses, more than 2 episodes in 6 months, or more than 3 episodes in 1 year. And steroids are something which we can easily become dependent on, so therefore we should be very careful. So steroid dependence, and when can we say that? More than 2 episodes while the child is on alternate steroid therapy, or within 14 days of stopping steroids. Now, in such cases where the child is has stopped responding to steroids or has become dependent to steroids, we obviously will not again go and use steroids. That is contraindicated. So what do we go and use? We use other class of immunomodulator drugs, steroid sparing drugs. So what are these drugs? They are levamisole or mycophenolate mofetil. Now we have come to the second class and another most important class, which is the steroid resistant nephrotic syndrome. Now, when can we say that this patient is having steroid resistant nephrotic syndrome? If they are diagnosed and if there is lack of remission despite treatment with prednisolone at a dose of 2 mg per kg per day for 6 weeks, that is when we say that it is a steroid resistant case. 2 mg per kg per day for 6 weeks. And why does this occur? Steroid sensitive cases are because of minimal change disease. There isn't any lesion in the glomeruli, whereas steroid resistant cases are because of significant glomerular lesions. This is the most important difference. Glomerular lesions. What could be the possible glomerular lesions? Significant glomerular lesions. If you think about it, they could be focal segmental glomerulosclerosis, membranous nephropathy. It could be because of such conditions due to significant lesions. Now, there could be two types of resistance. One is primary steroid resistance and the other is secondary steroid resistance. Now, if you try to decode, it's quite obvious. Primary steroid resistance is that if a patient comes to my OPD and if I've given prednisolone 2 mg per kg per day for almost 6 weeks, and if the child is not responding from the first day, I haven't seen any improvement in the symptomatology, then I will classify that as primary steroid resistance, which is there is a resistance to the drug therapy from the beginning, from the initiation of the therapy. But then in case of secondary steroid resistance, the child has come to me to the OPD. Okay, this is the first episode. I have given steroid and the child responded well. And after about 2 weeks, the child again comes to me with episodes of the same symptoms. The second episode, which is a relapse. Now, in the second episode, I give steroids and the child does not respond to steroids. Right? So, this is what is called secondary steroid resistance, which means the child has become resistant to the steroid during the course of the therapy. The child responded in the first episode, but in case of a relapse, the child is not responding. So that is the point here. So in all patients of steroid resistance, it is a must to undergo kidney biopsy. We should do genetic testing to check if there is any mutated gene to rule out whether it is congenital nephrotic syndrome. Now this is an image of this is a normal glomeruli and this is a sclerosed glomeruli. As we can see here, this is completely sclerosed. It has become ischemic, and because of which the kidney function is impaired because the glomerular filtration barrier has completely lost its function, as it is completely scarred. It is sclerosed. Now, when can we say that it is congenital nephrotic syndrome? Another more important section. So, it is defined when it presents within 3 months of birth. Now, in congenital nephrotic syndrome, what are the possible genes which could be mutated? NPHS1, NPHS2, and WT1 gene. Have we heard about this gene somewhere? Yes, it is also the gene that is mutated in Wilms tumor. It causes Wilms tumor. So in NPHS1 gene, it is also called as a Finnish type. Why? Because it is this type of gene mutation is more common in the Finland, and it codes for nephrin. Now, why is nephrin so important? Why does a mutation in this gene cause something so severe? We'll look into that. Now, this is inherited as autosomal recessive. This is also inherited as autosomal recessive. NPHS2 gene codes for podocin, and then we have WT1 gene, and this leads to something known as Denys-Drash syndrome. Now, this is inherited as autosomal dominant, and if this gene is mutated, there is a very high chance the child also has ambiguous genitalia, and there is an increased chance of Wilms tumor. Now, so this is a zoomed in image of our podocytes. We have a food process over here. Now, this is the filtration slit. This will be a filtration slit. Now, this is a slit diaphragm. Now, the slit diaphragm is made up of nephrin. Now, when this nephrin is mutated in NPHS1 gene, as we can see here, it is mutated here. What happens is that this protein is not formed well. Therefore, the slit diaphragm becomes very leaky. It becomes leaky. So all the huge proteins, all the big proteins can also pass into the glomerular space and go into the urine. So therefore, in the congenital nephrotic syndrome, there isn't only selective proteinuria, it is not restricted to only albumin loss. There could be also globulinuria. There could be also other big proteins loss. So that's it. Thank you.